audience. I'm Dr. Ghosh, Professor in Institute of Midnapur Medical College, and our moderator will be Dr. P.C. Mondal, Associate Professor and President of Midnapur RP branch. So we have 6 presentations, 6 speakers are there, and I think the cases will be interesting. So we are going to start the program, and Dr. Mondal will. I'm handing over the mic to Dr. Mondal, P.C. Mondal. Moderator.
Good afternoon. Welcome everybody.
আমি একটু একটা just introduction করে দিই before starting the cases. Dr. Mondal, if you don't mind. Okay, so first of all, big thank you to Midnapur Medical College, to Dr. Tarapada Ghosh, to all the faculty, to Dr. Mondal, and to all the PGTs for taking on this clinical meeting and presenting these, I'm sure, what will be very interesting cases to us. I would like to introduce the judges for today, Dr. Madhushmita Sengupta and Dr. Madhumita Nandi. So these are two very senior and experienced academicians of WBAP, and they will be asking questions and then deciding who will take the first and second positions at the end of the meeting. So thank you again, and thank you to all the audience for joining. Over to you again, Dr. Mondal.
Today, our department I think what is uniformly here, very
একটু মাইকটা কাছে করুন, শোনা যাচ্ছে না ভালো করে। আর প্লিজ এভরিবডি এলস প্লিজ মিউট ইওর মাইকস। ডক্টর মন্ডল, একটু মাইকটা কাছে করুন।
So, two cases even I am not saying in my life. So directly I am going to be cases. Sir, you have the front there. My audible? Hello. Hello, madam. Hello.
হ্যাঁ, শোনা যাচ্ছে। এই আওয়াজটা তো ক্লিয়ার শোনা গেল।
I am directly going to the cases. The first case will be presented by Dr. Aditi Chaudhary. This case, the title is a heartwarming bubble of sachet. Actually, this is the tradition of IIT. So you select a title which is not very clear and make confusion to everyone. So the title is actually a heartwarming bubble of sachet. Presenter is Dr. Aditi Chaudhary.
Good afternoon, my respected dignitaries here. Today, my case is a heartwarming bubble of sachet. My patient, a 7-year-old female Neha residing in Kharagpur, West Bengal, was brought by her mother to the pediatric outpatient department, complaining of fever for last 2 months and easy fatigability for last 1 month. Fever was insidious in onset, low grade initially with evening rise of temperature, but was high grade for the last 5 days with increased sweating. The fever responded to paracetamol and was not associated with chills, rigor, or cough. Mother also complained Neha being anorexic and there was significant weight loss in the last 2 months. She also noticed Neha falling short of breath after playing for some time with her friends or going upstairs, which started 1 month back and gradually worsened, with now the child feeling breathless while walking to the toilet inside their house and felt comfortable while sitting or lying down with her head end elevated. There is no history of cough, hemoptysis, or paroxysmal nocturnal dyspnea, no history of joint swelling, abnormal movement, or any localized swelling over the body. There is no history of afternoon spike of temperature or any history of sore throat or impetigo. There is no similar history in the past or no history which suggests palpitation, syncope, cyanosis, or orthopnea. No other family member suffered from similar kind of illness. Her grandmother suffered from tuberculosis infection 3 months back and passed away. Sadly, no further details were known about her illness or cause of death. Neha was born out of non-consanguineous marriage vaginally in an institution at term with a birth weight of 2.9 kg and cried immediately after birth. There is no postnatal history of poor feeding or excessive sweating over the forehead or any history of poor weight gain. Neha attained all her developmental milestones as per age and was immunized as per national immunization schedule. Neha belonged to lower socioeconomic status with overcrowding present in her home, and her dietary intake reduced significantly during her illness to 900 kilocalories and 8 grams of protein per day. On examining Neha, she was conscious, alert, cooperative with periorbital puffiness. She preferred being examined in sitting position. She was febrile with moderate pallor and bipedal edema, and her pulse rate was 130 per minute. It was regular but low volume. There was no radioradial or radiofemoral delay or any special character, and all the peripheral pulses were palpable. Her blood pressure was 84 by 56 millimeter mercury measured in the right brachial artery in sitting position. Anthropometric examinations showed Neha was both stunted and wasted, with significant bilateral cervical lymphadenopathy. Her jugular venous pressure was elevated but was pulsatile, and on head-to-toe examination, BCG scar was present over the left upper arm. Cardiovascular system examination, on inspecting the precordium, there was visible pulsation outside the mid-clavicular line in the lower left precordium with no bulge or venous prominence. Apex was palpated at the 6th intercostal space, 2 centimeter lateral to the left mid-clavicular line. It was forceful and ill-sustained, and thrill was present. No epigastric pulsation was palpable, and trachea was palpated in the midline. There was no parasternal lift or any palpable second heart sound in the pulmonary or aortic area. Percussion was not done. On auscultation, first and second heart sound was audible. A grade 4 high-pitched pansystolic murmur, which was best heard over the apical area, was heard with no definite radiation. There was no change in character with posture change. Auscultation of the other areas were within normal limits, and no adventitious sound was heard. Respiratory system examination showed trachea in the midline on palpation and bilateral basal crepitations. Gastrointestinal system examination showed on palpation liver was palpable 8 centimeter below right subcostal margin, which was soft with rounded borders and smooth surface and tender. Liver span was 15 centimeter. Spleen was not palpable and ascites was absent. Central nervous system examination was within normal limits. On investigation, her hemoglobin was 8.2 gram per deciliter with increased total leukocyte count with lymphocytic predominance. CRP was elevated, ESR was also elevated. ASO titer was 200 international unit and serum albumin was 3 gram per deciliter. Chest X-ray showed cardiomegaly with pericardial effusion. ECG all 12 leads showed left axis deviation with no ventricular hypertrophy. Mantoux test was positive, showing an induration of 15:17 millimeter. Sputum for CB-NAT was negative and 2D echo was pending. So my diagnosis till now would be acute rheumatic fever with congestive cardiac failure, dilated cardiomyopathy, pericardial effusion, congenital heart disease with left to right shunt with congestive cardiac failure, and infective endocarditis. So I started managing initially Neha with fluid restriction, complete bed rest, moist oxygen, paracetamol, empirical antibiotic, injection Lasix was started at 2 milligram per kg per day, and intake output chart was monitored. On day 3 of admission, Neha was still febrile with tachycardia, tachypnea persisting. She was on moist oxygen. 120 ml of BRBC was transfused, and injection Lasix was increased to 3 milligram per kg per day. Further reports came which showed urine culture, no growth, malaria parasite and dual antigen, dengue, IgM, and scrub typhus IgM came negative. 2D echocardiography was done, which showed a 6 into 5 centimeter structure found posterior to the left atrium, the single narrow opening connecting to the left ventricle, compressing the left atrium with loculated pericardial effusion. This is an image of the 2D echocardiography still, where the X marked area shows the sac-like structure connecting to the left ventricle through a narrow opening. And on Doppler, we can see that during systole, the blood from left ventricle flowed to the sac-like structure. There was turbulence present, and then it again came back from the narrow opening to the left ventricle during diastole. And there was a loculated pericardial effusion. Day 5 of admission, Neha was still febrile. Her congestive cardiac failure could not be managed medically. Blood culture report came which showed no growth. Injection Lasix was increased to 4 milligram per kg per day. Ceftriaxone was omitted and cardiology consultation was sought. They opined to add enalapril and to do cardiac CT. However, diagnostic pericardial tap was withheld due to increased risk of trauma to the unknown sac-like structure. CCT angio was done, which showed a large contrast-filled sac noted in the left side of the heart communicating with the left ventricle through a narrow opening below the mitral valve. It measured 6.2 into 5.7 into 5.4 centimeter, and it caused compression over the left atrium. It was a large left ventricular aneurysm. This is a picture showing the CECT where the increased contrast has been seen in the sac filled area, which is the left ventricular aneurysm. On day 7 of admission, fever was still persisting. There was no response to IV antibiotics. At this point of time, we considered tuberculosis because there was presence of constitutional symptoms. Contact history was positive and Mantoux test was strongly positive. So anti-tubercular drugs were started. On day 21 of illness, we saw that the fever was subsided, congestive cardiac failure controlled, CRP reduced to 10 milligram per liter, and repeat chest X-ray showed reduction in the cardiomegaly, the heart size. 2D echocardiography done on day 21, which showed chink of pericardial effusion. Injection Lasix was brought down to 2 milligram per kg per day, and enalapril continued at the same dose of 0.1 milligram per kg per day. Hence, my final diagnosis here is left ventricular aneurysm with congestive cardiac failure, probably due to tuberculous etiology, grade 4 protein energy malnutrition. Patient was discharged in stable condition with anti-tubercular drugs, oral Lasix at 2 milligram per kg per day, and tab enalapril at 0.1 milligram per kg per day. Follow-up is awaited. A similar case report was dated in 1983 was found where a 3-year-old child came with congestive cardiac failure and could not be managed medically, after which cardiac catheterization was done, which showed 2 left ventricular aneurysm of 2 centimeter and 3 centimeter. However, on surgical attempt to close the aneurysm, the patient died in the OT table, and post-mortem histopathological examination detected granulomatous inflammation. There is a similar case study of 19 patients done in 1987, which there were 19 patients overall, out of which 3 patients developed left ventricular aneurysm, and only 1 patient could be diagnosed in the antemortem period. A review done in the 2022 of tuberculosis of the heart, which proposed a pathophysiology of the cardiac tuberculosis, which could be due to 2 reasons. One, it could be due to direct seeding from the hilar or mediastinal lymph node to the cardiac chamber. It has been found that right atrium and right ventricle were most commonly affected, probably due to increased affection of the right hilum or right mediastinal lymph node. Another proposition was given that due to TB arteritis, there could be ischemia of the ventricular wall leading to aneurysm. Thank you.
So this is our first case. The second case is speaker is Surajit Bhattacharya. He speaker of the case of a ongoing plan.
Hello. Can I make 1 or 2 comments about Aditi's presentation?
Okay.
Actually, Aditi very well presented, but just 1 or 2 points. I think tuberculosis should have been considered initially also because of Mantoux test and such pericardial effusion. Tuberculosis should have been considered at the beginning of your case management. And number 2, though your presentation was very nice, you seem to have worked very hard on this case, but especially the initial slides, actually those slides looked too clumsy. Actually, the slides should be like, there should not be more than 4 or 5 lines in each slide, and you're not supposed to read everything, write down everything on the slides and read word to word. Slides are just to, with small 1 or 2 words, bullet wise, you make a list and then you present. This is all I have to say. Thank you.
I would also like to make a comment that I would like, according to the diagnosis, I would like the question the utility of giving Lasix. I mean, why did you give Lasix?
Ma'am, because the patient presented with congestive cardiac failure. There was elevated jugular venous pressure with hepatomegaly and bipedal edema.
Bipedal edema doesn't respond to Lasix. I mean, your total protein was not very low, was it?
No, ma'am, it was 3 grams per deciliter.
3 grams per deciliter.
Acha, can I ask a question? I am Dr. Subhashish Bhattacharya from CSS.
Welcome.
Go ahead.
Hello?
Yes, go ahead.
Yes, sir.
জিজ্ঞেস করতে পারি একটা?
Please.
আচ্ছা, that's right. এটা কিন্তু we should consider tuberculosis at the initially because this kind of effusion is very common. And one thing I wanted to ask that have you started along with this ATD steroid, any steroid?
যে 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 রেফারেন্সটা দেখানো হয়েছে ওটা মিলিয়ারি টিউবারকুলোসিস
Actually, what happens that the pericardial amount of pericardial effusion is very small because there is only cheek of effusion. We are more concerned about the aneurysm factor because when there is large aneurysm, that is causing also giving pressure with the right ventricle as also the left atrium. So that's why there is also left ventricular failure is there, but also there is right ventricular failure is also there. Because there is the forward flow, when there is systole, there is contraction of the left ventricle and the blood is going in two ways. One is going towards the aorta and another is going back to the aneurysm. So that's why we think that there is a failure, and also because as there is pressure over the right ventricle as also the left atrium, that causes of the right ventricular dysfunction. So it is the pericardial effusion factor is not very problematic. The problematic was is the aneurysm. So that's why we haven't started steroid. Actually, even after after starting ATD, the patient responded, and with other conservative management for congestive cardiac failure.
And second one is heart.
The patient actually here is the aneurysm. We'll have to think that in case of tuberculosis, there can be aneurysm. There is the left ventricular aneurysm. We are much more concerned with the left ventricular aneurysm. Only if it is diffusion, pericardial effusion, then we'll have to do pericardiocentesis and examination. But initially, ventriculography could not be done. Initially, as the effusion is small, so as there is aneurysm, before doing the Doppler study, we are a little bit, there will be a little bit risk to put the needle over the pericardium. That's why we went started steroid.
And second point is, Madam has rightly said, why is the basically what is
Achha, there are two questions in the chat box. One is from Dr. Arun Manglik. What do you expect to be the outcome of the aneurysm? Second from Dr. Asha Mukherjee. What is the cause of the aneurysm?
Actually,
So I
what
think
happens,
these can be the last two questions for this case.
hello, actually, what happens after that, the patient was transferred to the patient was transferred to SSKM hospital, and that patient hasn't come back. So,
But generally from the literature, what is the outcome of these aneurysms? Aditi, you looked at the literature. Can you say from the previous cases, what is the outcome, long-term outcome of the aneurysm?
Outcome, it required surgical management, ma'am.
Okay, I think we'll go on to the next. We have 5 more cases.
okay. So the next case is a wandering giant. The speaker is Surajit Bhattacharya. So please explain about this present.
Good afternoon, respected dignitaries, my teachers and colleagues. I am Dr. Surajit Bhattacharya. I am presenting a tale of a wandering giant.
A little bit louder.
ঠিক আছে, শোনা যাচ্ছে. Please start.
slide.
The slides are not moving. Yes.
My patient, Rahul Murmu, a 5-year-old male child, presented to us with a provisional diagnosis of suspected bleeding disorder from Shalboni Hospital. Coming to presenting complex, Chip's fever was for last 2 months, with swelling over left elbow joint for last 2 months and swelling over bilateral hip, left thumb, and left ankle for last 1 month. Coming to history of presenting illness, fever was insidious in onset, low grade, intermittent in nature. Most of the time it was in evening, associated with swelling over left elbow joint for same duration, and it was gradually progressive and increasing in size. It was also followed by a swelling in the left thumb, bilateral hip, and left ankle. It was also associated with discharge of pus from the left elbow and left lower back and left thumb. It was associated with discharge of one small piece of bone-like material from left thumb. It was also associated with pain over the swelling, with difficulty in walking and decreasing in appetite, with history of weight loss for last 1 month. No history of cough, cold, rashes, convulsion, and any bleeding manifestation with pain abdomen and vomiting. No history of trauma and contact with TB patient. Past history, birth history, family history, immunization history, development history, and feeding history was normal. There was no abnormality found. Socioeconomic history shows patient falls in lower socioeconomic class according to modified Kusami scale. On clinical examination, temperature was 99 degrees Fahrenheit. There was pallor was present, cyanosis, icterus, clubbing, edema was absent. There was no lymphadenopathy. On local examination, presence of swelling over left elbow joint and left thumb and bilateral hip and left ankle. There was no active discharge from swelling and no redness, no rise of temperature. But there was tenderness over the swelling. There was presence of ulceration over left elbow joint with no undermining edge, with decreased range of movement of the same joint. Tenderness was present over lower back and there was abnormal limping. There was no sternal tenderness. This is the picture showing ulceration over the left elbow and lower back. On other systemic examination, on GI examination, there was no organomegaly and other systemic examinations were within normal limit. On anthropometry, weight was 12 kg, it was less than 3rd centile, height was 98 centimeter, it was also less than 3rd centile, mid upper arm circumference was 11 centimeter and upper segment ratio was 1.31. After admission, we started empirical antibiotics and conservative management. 4 days after admission, patient started complaining lower back pain for which he could not sit for long duration. On investigation, hemoglobin was 6.4 gram% with microcytic hyperchromic anemia with moderate anisopoikilocytosis. Other investigations were within normal limit. Fever profile was sent. There was no abnormality found in fever profile. PT-INR was normal. HBS antigen anti-HCV was non-reactive. HIV 1-2 RA factor ANA was negative. MAN2 test was negative. Gastric lavage for CBNAT and AB was also negative. Chest X-ray was normal. X-ray bilateral wrist shows small, well-defined lytic lesion with sclerotic margin in distal radial metaphysis. X-ray of left elbow shows lytic lesion with bone erosions in coronoid process of ulna. Bone erosion also seen in epiphysis of radial head with diffuse periarticular osteopenia and soft tissue swelling. X-ray of left knee shows small, well-defined lytic lesion with sclerotic margin and narrow zone of transition in left distal femoral metaphysis and knee joint space was normal. X-ray spine shows spondylosis of L1 vertebra. Other joint of X-ray was normal. X-ray skull was also normal. This is this X-ray. Now coming to differential diagnosis, we have made differential diagnosis of chronic osteomyelitis, multiple myeloma, fibrous cortical defect, tuberculosis of bone, metastasis, and eosinophilic granuloma. Now we did bone marrow aspiration, which shows no abnormality, and now after bone marrow aspiration, as we could not find reach the diagnosis, so we did MRI. So MRI of left wrist suggests cellulitis in dorsal aspect of left wrist with small cortical based lesion in ventral aspect of distal radial diaphysis, query cystic tuberculosis. MRI of right wrist shows small focal altered signal intensity area in ventrolateral aspect of distal radius. MRI of left elbow shows infective arthritis of left elbow joint with moderate abscess. MRI left knee shows small well-defined cystic swell in left distal femoral metaphysis and epiphyseal region. MRI bilateral hip shows moderate fluid collection in right gluteal region between gluteus medius muscle, query cold abscess. MRI LS spine is suggestive of infective spondylodiscitis with collapsed vertebra, prevertebral and paravertebral and epidural abscess. There was small abscess in posterior paraspinal region. These are the pictures of the one. Now, suspecting TB, we did USG guided FNAC from ankle swelling, which revealed dispersed lymphocytes and few clusters of epithelioid cells forming granuloma likely tubercular etiology. So, considering all above finding, tuberculosis was provisionally diagnosed and we did serum immunoglobulin profile to rule out immunodeficiency, which was also normal. We started ATD according to our NDCP guidelines after the diagnosis and discharged the patient on stable condition after 7 days. 2 months after discharge on follow-up, patient shows clinical improvement with disappearance of the swelling and increase in range of movement of the elbow joint. This is the case report showing multifocal tubercular osteomyelitis mimicking widespread bony metastasis. Now, learning points: tuberculosis should be considered in patients with multiple round hypodense-like lesions of the skeletal system, especially in tuberculosis endemic countries. MRI is valuable for diagnosis and prognosis, but biopsy or definition is required for confirmation of the diagnosis. Thank you.
So there is no more time. So only 1 or 2 questions can ask.
ডক্টর মন্ডলের কথা শোনা যাচ্ছে না একদম। হ্যাঁ, questions, please, 1 or 2 questions, judges.
Yes, this is was very nicely presented. But regarding immunodeficiencies, primary immunodeficiencies still remains a possibility because you have just done immunoglobulin level, which could be normal, but there are immunodeficiencies of other immune limbs could be involved, and even there it's coming up MSMD, mycobacterial Mendelian inheritance of mycobacterial susceptibility. So that is itself an immunodeficiency where those patients are more susceptible to severe and repeated infections with mycobacterium. So I don't know, those are all genetic diagnosis, but it might not be possible in our setting. But we have to do thorough investigations regarding.
Actually, the age of the child is 5 years.
চলে যাও।
Hello. Actually, the age.
এরকম করে না দেখে
Audible.
Yes.
Madam.
Yes, sir.
Actually, the age of the child was 5 years, and as it was a 5 years old child, and as there is no history of recurrent infection in past, so if it is there is any immunodeficiency, it can be acquired immunodeficiency. So maybe possibility the possibility of acquired immunodeficiency.
Actually, it's not there are many immunodeficiencies which might present later also, and as I said, one immunodeficiency where mycobacterial susceptibility is characteristically there. It is MSMD, mycobacterial Mendelian inheritance of mycobacterial susceptibility. The tests for those are also available, but we should keep those things in mind, because tuberculosis, multifocal osteomyelitis by tuberculosis is not it's very rare.
One question actually, did you exclude, and that should be done actually, did you exclude the brucellosis? Brucellosis may present like this kind of osteomyelitis, especially from rural population. We should exclude brucellosis also.
আর হাতের এক্সরে কি করা হয়েছিল, ড্যাকটিলাইটিস বা কিছু কি পাওয়া গেছে? হাতের এক্সরেটা একটু দেখালে ভালো হতো।
That will come in differential diagnosis definitely, but as the MRI is suggesting of tuberculosis, and as also the analysis suggests that there is granuloma formation, actually the multiple osteolytic lesion may present, maybe there is maybe chance of tuberculosis, that is what we are highlighting. It can be differential diagnosis definitely, but MRI most of the cases done several places, and that are also suggestive of that. Categorically write down that it is a case of, maybe a case of tuberculosis, and as also the definition also suggested that there is a granuloma formation and tuberculosis. So, and it ultimately responded to the tuberculosis drug.
Okay, fine. Actually, this is a rare association of a relatively common disease.
Hello.
AC.
Can you hear me?
Hello.
শোনা যাচ্ছে মিহির বলো।
So how was the treatment, what was the response to treatment? Because it may not be the Mycobacterium tuberculosis, even if it is the diagnosis, the tubercular osteolytic lesion. So it may be the atypical mycobacteria, if it is especially in a child with the 5 years, as the madam was pointing out the Mendelian inheritance to susceptibility to Mycobacterium tuberculosis. So there may be not the atypical mycobacteria, maybe the causative organism. So response, I'm interested to know how was the response to treatment with ATD?
I think they mentioned that the follow-up was good. Patients responded.
Swelling over the elbow was diminished, and there was range of movement was improved, and he was gaining weight also. And fever was also subsided.
May I ask a question? May I ask something?
Sure.
I'm just curious about how common do we have solitary lesions in tuberculous osteomyelitis versus multiple lesions? As far as I know, solitary lesions are much more common. In view of that, the idea of looking into the immunoglobulin or immune deficiencies is very important, particularly in view of the fact that the child had a gross failure to thrive as well. The child was not thriving very well at all. So in view of all this, I think we should look into the immune deficiency in a better way, apart from only doing the immunoglobulin levels. Apart from that, since the child is improving very well, I mean, what I can gather, I think that can also wait, and we can subsequently follow up and look into these matters at a later date also. That would be my comment.
Okay, thank you for the comment. The third case is actually a rare association of a relatively common disease. The title is Swedish storm in a pale child. And the speaker is Dr. Santanu Rai.
Good evening, delegates. I'm Dr. Santanu Rai, third year PGT Department of Pediatrics in Vidyavan Medical College. I am presenting a topic of the today's discussion is Swedish storm in a pale child. Emergency presentation and examination. A 1 year, 6-month male child presented at the pediatric ER with history of shortness of breath for the last 12 hours. The child was suffering from cough and cold for the last 3 days, and he developed polydipsia and polyuria for the last 24 hours. There was no history of fever for the last 3 days. On examination, his GCS was low, which was 7/15. Pulse was 162 per minute, regular, low volume. BP was 90/52 millimeter mercury. Pupils was bilaterally dilated, suggestive reactive. Pallor was present. Respiratory rate was 68 per minute with presence of subconscious suction and bilateral chest retractions, and with bilateral vesicular base sounds and auscultation. SpO2 was 98% in room air, and liver was 4 centimeter palpable below the right costal margin along the mid-clavicular line. We measured the capillary blood glucose, which was more than 500 milligram per DL, and ABG showed a pH of 6.968, PCO2 which was low with 11.7 millimeter mercury, and bicarbonate was 4.4 millimole per liter, which denoted metabolic acidosis, and urinary ketone bodies was positive. Investigation showed chest X-ray, which was done portably, showed bilateral normal lung fields. CBC showed a pallor. It was a hemoglobin of 1.5 gram %. Platelet rate was slightly lower of 81,000 per cubic millimeter, and leukocyte count was 5,500 per cubic millimeter. RBS was 480 milligram per DL, and urinary urinalysis showed reducing substances. Blood culture showed no growth. Past history. The child was previously hospitalized at 4 months before at 1 year, 2 months of age with diabetic ketoacidosis along with pallor, and he was started on subcutaneous insulin therapy for type 1 diabetes mellitus. He had history of recurrent pallor and was previously hospitalized thrice for blood transfusions. He also had history of failure to thrive and recurrent mucocutaneous candidiasis. Antenatal, natal, and postnatal history. The child was firstborn, and the mother had no antenatal complications. The child had no significant birth history, and there was no postnatal complications. This family history was taken, and the family history, none of the family members of the child had history of diabetes mellitus. The following investigations that were done during the past hospitalizations raised our suspicion of presence of some metabolic or genetic entity
caused recurrent anemia and mucocutaneous candidiasis, and later development of type 1 diabetes mellitus and episodes of diabetic ketoacidosis in the child, along with the history and physical examinations, which were described below. CBC with peripheral blood smear analysis showed a hemoglobin of again pallor, 4.7 gram per DL with a normal leukocyte count of 8,500 and platelet count normal of 2,47,000. But in PBS, there were two populations. One was with microcytic hypochromic anemia and another was with microcytic normochromic anemia, which was a dimorphic picture. Reticulocyte count 5% and reticulocyte index 1.5. Serum folate level was normal of 7.2 nanogram per ml with serum cyanocobalamin or vitamin B12 of normal range 624 picogram per ml. The celiac profile we have done and the anti-TG antibody was also negative. Iron profile showed a normal serum iron content and transfer saturation within normal limits, also TIBC. Serum ferritin was raised from 2176.2 nanogram per ml. HPLC of both the mother, father, and the child was of normal pattern. We did a bone marrow analysis which showed erythroid hyperplasia with mild degree of megaloblastic changes. Associations for the in order to find the cause of the association of diabetes mellitus, we did to eliminate the hyperparathyroidism. We did serum calcium, which was also normal, phosphate, ALP, thyroid was also a normal level, and also the summary. The child had recurrent history of pallor. The child later developed type 1 diabetes mellitus and suffered from 2 episodes of diabetic ketoacidosis. The child had associated history of recurrent mucocutaneous candidiasis and gout failure. Physical examination showed only hepatomegaly. Peripheral blood smear showed a dimorphic picture of anemia. Bone marrow study showed megaloblastic changes. Serum folic acid and serum B12 level were normal. Thyroid profile, HPL studies were normal. Anti-TTG antibody was negative. Only ferritin was highly raised, and the other components of the iron profile was normal. So, based on the available clinical profile investigation and review of the existing literatures, we decided next generation sequencing after proper parental counseling. And the next generation sequencing report revealed SLC 1982 gene deletion at chromosome 1, which manifests as thiamine responsive megaloblastic anemia syndrome or Rogers syndrome of autosomal recessive inheritance. Emergency management, because of the child was in shock and he was in low GCS, so the child, in order to secure the airway, he was intubated, put under mechanical ventilation, and also a central line was established, a right femoral vein. The child was managed conservatively as per the protocol for the management of diabetic ketoacidosis. After the correction of acidosis, the child was successfully placed on subcutaneous insulin therapy. He also received 2 units of PRBC for anemia correction. And initially, the child was discharged with daily subcutaneous insulin regimen after proper parental counseling, awaiting the next generation sequencing report. After receiving the report and finally getting the diagnosis, we started on thiamine of 10 milligram per kg per day per oral daily, along with subcutaneous insulin regimen, and the child was kept on monthly follow-up. During the follow-up, there was no further pallor and weight gain was adequate. The blood glucose was also in tight control. After 2 months of therapy with thiamine, the CBC and PBS was repeated again, and the child had a normal CBC picture. And the child is currently on thiamine and subcutaneous insulin therapy. The BAES study of the child was normal in both years as of now. Discussion. The thiamine responsive megaloblastic anemia syndrome or Rogers syndrome is caused by homozygous mutation of SLC 1982 gene at chromosome 1. The disorder is characterized by anemia, diabetes mellitus, and sensorineural deafness, but all the 3 features may not be present typically initially. Anemia, sometimes also diabetes, improves on high doses of thiamine. Other more variable features may include optic atrophy, congenital heart defects, and short stature and stroke. Thank you.
So, if there is any question or query or comment from the audience, anybody can ask a question.
I think that's a really very interesting and very well worked up case. But how does what is the physiology of the condition? Why does this genetic defect cause that we can understand why it might cause the megaloblastic anemia, but how does it cause the diabetes?
But there were some studies previously, but hypotheses have been made previously, not a definitive case, because the genome that is affected, it has some autoimmune effect. Means it has an autoimmune effect, and it actually diminishes the parietal beta cell. The endocrine beta cells of the pancreatic region. So therefore, insulin deficiency ensues later, and maybe the child comes on diabetes. So these only hypotheses have been made till now, but not like that. It's a finally definitive thing.
And are there a lot of cases already described?
No, ma'am. Only 2 to 3 cases have been described. But in 2 to 3 cases, ma'am, which I have studied, only one case had this association of diabetes, and the other 2 did not have diabetes at presentation.
Okay, and did you mention about consanguinity because of the autosomal
Yes,
recessive
ma'am.
inheritance?
Consanguineous marriage. There was no history of
Oh.
consanguinity.
Okay. Any other questions from the judges or anyone else?
What is
Dr.
the pro-
Manglik? Sorry, Shubhashish, please go ahead.
What is the did you went for did you this thing serum blood thiamine level when you diagnose the thiamine responsive megaloblastic anemia?
No, sir. Serum thiamine level is not available locally in our city. So we decided, since if nothing was matching according to the initial differential diagnosis, we straight up went for the next generation sequencing. After suspecting that it could be, by studying the previous literatures and the textbook also, we suspected something, and we thought of to give a shot of giving a NGS directly, because estimating the thiamine dose here was not possible, because no other laboratories outside in our city was doing that.
So how long you have to take this thiamine, high megadose thiamine throughout the life?
In the literatures and in the textbook also, it has been said that the child has to be put on the lifelong dose of thiamine, and the child could be correct anemia, and also diabetes can be corrected. Since we have been able to successfully eliminate the cause of failure to thrive, along with that anemia has also been corrected, and the child has been growing adequately now. So we are trying to give thiamine in the same dose, and also curb the subcutaneous insulin therapy. After that, we will try to stop the thiamine again, and we see the response. If the response is okay, we will go. Otherwise, we will continue giving thiamine.
Is there any simple thiamine tablet is available? Only thiamine tablet in market? I don't know.
Yes, sir. I have been able to decrease the insulin dose with 20%, I think, from the.
Only thiamine.
No,
Yes.
thiamine, is there, could you procure just thiamine on its own to give the child?
Yes,
That
ma'am.
is what.
Thiamine has been given.
Okay. Any other questions, Madhushmita Bhi?
এটা হেমাটোলজিস্টরা ইউজ করে অ্যানিমিয়ার ইনভেস্টিগেশন রে, এইভাবেই ওরা ডায়াগনোস করে, কিন্তু ডায়াবেটিসের অ্যাসোসিয়েশনটাতে খুব সাবধানে তো ইনসুলিনটাকে কমাতে হবে। যদি থাইরয়েডে রেসপন্ড করে তাহলে তো ডায়াবেটিসটা সঙ্গে সঙ্গে কমে যাবে আর কি, মানে আস্তে আস্তে ওটাকে রিডিউস করতে হবে ইনসুলিনের ডোজটা।
Okay.
ঠিকই আছে, I agree with the diagnosis.
Thank you. Thank you. Let's proceed.
Good evening, all the dignitaries present here, my teachers and my colleagues. Today, my topic of presentation is a thin on the ground case of yellow baby. So my patient was Anupam Singh, 9 months age, male baby, belonging to Hindu religion, admitted on 5th April, chief informant being mother, residing in Paschim Mednipur, came with chief complaints of itching of whole body for last 2 months, with raised blackish skin lesions for 2 months, fever for 15 days 2 months back, and yellowish discoloration of eyes and body, and dark colored urine for last 1.5 months. The child was apparently well 2 months back. Thereafter, he developed itching over the whole body for last 2 months, which aggravates and worsens at night and precipitates with heating and relieved by cooling. Along with itching, he also developed subcutaneous hemorrhagic nodules for last 2 months, which started from the midline of the chest, expanding to the left lateral aspect of the chest and even on the back of the trunk. Following which, the mother took the baby to a local doctor where he was prescribed to take antihistaminic drugs. This was followed by fever lasting for 2 weeks, which appeared to be intermittent in nature, not associated with chills and rigors, with brief period of normalization. Later, the child developed yellowish discoloration of eyes and dark-colored urine, which persisted for 1.5 months. There was no associated history of vomiting, abdominal pain, loss of appetite, pale-colored stool, no history of hematuria, no history of nose or gum bleeding, and no history of traveling. No past was taken to a local doctor for pruritus, where he was prescribed to take antihistaminic drugs. And later on developing jaundice, the baby was taken to local co-ops. No past history of similar illness, and antenatal history, birth history, and postnatal history was uneventful, and the baby did not have any history of neonatal jaundice. The child has reached all the developmental milestones according to his mother, and immunization history and dietary history was within normal limits. There is no recent history of disease in the family, no history of chronic liver diseases in other family members, no history of psychiatric illnesses in any of the family members, and no history of consanguinity. The child lived in a Pakka house, and the child belonged to lower socioeconomic class according to modified Kupuswamy scale. On clinical examination, the child is well nourished, conscious, well oriented, irritable, crying, and but consolable and moving all 4 limbs. Anthropometry showed normal. The body weight was 8.9 kgs, length was 76 centimeters, which was between 58th and 97th percentile. Head circumference was normal, that is 45 centimeters. On general survey, facies was normal, but mild pallor was present, and icterus was also present. Cyanosis, clubbing, edema, lymphadenopathy, all were absent. Temperature on admission was 100.5 degrees Fahrenheit. Pulse rate was 137 per minute. Regular normal rhythm, normovolumic, no radio-radial delay, and all peripheral pulses were palpable bilateral. On blood pressure was normal, 85 by 60 millimeters Hg, and respiratory rate was 30 per minute. On local examination, mouth, hand, legs, all were normal, and hair was also normal. But a tinge of yellowish discoloration was present on the undersurface of tongue. On systemic examination, gastrointestinal examination on inspection, the shape of the abdomen was normal, and flanks were not full, umbilicus was normal, subcutaneous hemorrhagic nodules were present on the anterior and posterior abdominal wall, and no visible veins, gastric or intestinal peristaltic movements were present. All the hernial sites were normal, external genitalia were within the normal limits, no dilated veins or scars or sinuses were present. On systemic examination on palpation, superficial palpation showed no local or generalized tenderness, no abdominal distension, and no fluid stream.
Sure, opening হবে।
Please mute your mics, please. Carry on.
The liver is palpable 2 centimeters below the right costal margin in the right midclavicular line. The consistency was firm, border rounded, surface was smooth, and tenderness was absent. There is absence of any pulsatility also. On percussion, there was absence of shifting dullness, and on auscultation, normal intestinal peristaltic sounds were present. Other systemic examination were normal. So by history and clinical examination, we came to a differential diagnosis of acute viral hepatitis, chronic viral hepatitis, autoimmune hepatitis, overlap syndromes like primary biliary cholangitis and primary sclerosing cholangitis, metabolic disorders like Wilson disease, non-alcoholic steatohepatitis, alpha-1 antitrypsin deficiency, etc. So based on these differential diagnoses, we started our investigations, and the hemoglobin came out 6.3 grams per DL. There was thrombocytosis, that is platelet count was 6.8 lakhs per cubic millimeter. WBC count was 14,000 per cubic millimeters. Neutrophil was 65%, lymphocyte was 35%. Liver function test was done. Total bilirubin showed 16.72 milligrams per DL, which was highly raised. Direct was 8.93 milligrams per DL. Indirect was 7.79 milligrams per DL. SGOT was 173 units per liter. SGPT was also raised, that is 76 units per liter, whereas alkaline phosphatase was normal, that is 300 units per liter. Total protein is 8.5 grams per DL, albumin 4.9 grams per DL, and globulin 3.6 grams per DL. Peripheral blood smear was also done, which showed normochromic normocytic anemia with retic count as 0.6%. Fever profile showed MPDA negative, dengue NS1 IgM negative, urine routine and microscopic examination all were normal. Fetal tests, scrub typhus IgM were non-reactive. Blood culture showed no growth of organisms. Hepatitis, ruling out all these, we went for hepatitis A and hepatitis E IgM antibodies, which were also non-reactive. Then we went for HBsAg anti-HCV testing, which also came out non-reactive. Lipid profile was normal, but coagulation profile was done, which showed prothrombin time highly raised, that is more than 100 seconds, APTT 101.1 seconds, and INR as 2. Leptospira IgM was done, which showed non-reactive, and ultrasonography of whole abdomen showed sequelae of infective hepatitis. Thinking of all these, we wanted to rule out other causes of acute liver failure in chronic liver diseases like Wilson disease. So we went for serum ceruloplasmin, which was borderline normal, that is 47 milligrams per DL. Normal range showed between 15 to 30, and 24 hours urinary copper excretion, which showed 29.87 micrograms per day. And we also did a slit lamp examination, which turned out negative for KF ring. So Wilson disease was ruled out. Based on these initial investigations, conservative management was done, PRBC transfusion was done, and since the child was going into acute hepatic failure, we provided the child fresh frozen plasma and injection vitamin K, following which ecchymosis started to resolve and coagulation profile came down to normal. Then we thought of ruling out autoimmune causes. So we opted for doing anti-nuclear antibody, which came out negative. Anti-smooth muscle antibody, which was highly raised, that was 1:100 titer, and the serum sample was positive. Autoantibodies against LKM was negative, and serum immunoglobulin G was done, which is 15.6 grams per liter, which was highly raised. Magnetic resonance cholangiopancreatography was done, which was also normal. At last, we went for liver biopsy to confirm the diagnosis. The portal tracts showed moderate lymphoplasmacytic infiltrate with mild interface hepatitis. The hepatocytes within the lobules showed ballooning degeneration, 40 necrosis and canalicular cholestasis, all were absent. The impression showed chronic hepatitis with mild activity and moderate chronicity. So this is the biopsy sample. So as far we have discussed, according to the scoring system present in the autoimmune hepatitis, our child had anti-nuclear and anti-smooth muscle antibody more than 1:80. Our child had 1:800. So the score was +2. And serum IgG was more than upper limit of normal. So the score was +1. And the histopathologic findings were compatible with autoimmune hepatitis. So it was +1. When the hepatitis viral markers were negative and the score was +2. Aggregate score without treatment came out equal to +7. So the child was definitely diagnosed as autoimmune hepatitis. Coming to the treatment, we started the child on tablet ursodeoxycholic acid, and after confirmation of diagnosis, the child was started on tablet prednisolone at a dose of 2 milligrams per kg per day and was discharged after starting a steroid and gradually tapered over 2 months and then omitted. On follow-up after 7 days, total bilirubin dropped down to 10 milligrams per DL, and at the end of 2 months, a repeat liver function test was done, which showed bilirubin further came down, which showed 0.9 milligrams per DL, where direct bilirubin was 0.3 milligrams per DL and indirect was 0.6. SGPT was 29 units per liter and SGOT was 64 units per liter. This is the baby. Before starting steroid, there was complete yellowish discoloration of the whole body, and after 2 months, there was complete disappearance of yellowish discoloration as well as the hemorrhagic nodules. 3 months after the discharge, the patient showed disappearance of yellowish discoloration of sclera and the body. So our take-home message is any child presenting with subcutaneous hemorrhagic nodules and jaundice, after ruling out the common causes of acute viral hepatitis, in my case, since the baby is 9 months of age, after ruling out idiopathic neonatal hepatitis and Wilson disease, autoimmune hepatitis should be highly suspected.
since it can occur at any age and prompt treatment should be started since the baby might go into acute hepatic failure, which may be highly fatal. So thank you.
Okay, thank you.
Very well presented. Just one or two small questions. From the beginning itself, this case seems to be, there are many clues regarding chronicity of this liver disease. It was probably chronic liver disease from the beginning. But what was the serum globulin initially? That should be the first clue towards the autoimmune origin of chronic liver disease. You were saying serum IgG was very much raised, but when you do LFT and the albumin and globulin report comes, if globulin is more than 6, or it's literature says that globulin more than 6 is probably more or less is very much in favor of autoimmune hepatitis.
Yes.
And 4 to 6 is equivocal, but serum globulin initially we should see to it that serum globulin is very high. Without waiting for other reports, we can just investigate further regarding autoimmune origin of liver disease. And number 2, you have treated only with prednisolone, but I don't at present remember the actual regimen. But as far as I remember, that the recommended regimen is prednisolone should be given along with azathioprine.
Yes, ma'am. It is
And
not available in our institution. So we started the child on tablet prednisolone only.
Okay, and there is a rule of repeat liver biopsy because the treatment, the duration of treatment and tapering the dose or titrating the dosage of prednisolone and azathioprine will depend on the histopathological response to the drugs.
Yes, ma'am, but we did not want to perform another invasive.
Not so soon, probably after years, after 1 year or 2 years. But there are definite recommendations regarding that. I tend to forget what actually is the recommendation, but there are recommendations in literature. How often should you be repeating biopsy?
Yes, ma'am. Before stopping tablet prednisolone, we should go for liver biopsy.
Yeah.
But we did not want to perform another invasive procedure over the baby.
And
That's why.
also serum globulin, at least if not IgG repeatedly, but serum globulin also will may guide us regarding treatment.
Yes, ma'am. Yes.
PT hepatitis normalize করে গেলে তখন biopsy করতে পারো।
Yes, ma'am.
Okay, thank you. Very well presented.
Thank you, ma'am. Good afternoon, all the dignitaries present here. My case is Sheikh Sarif Ali, 2 years male child residing at Kespur, admitted in MMCH on May 2022. Informant is mother who is reliable. Chief complaint breathlessness for 1 day. Patient was apparently well 1 day back. Suddenly she noticed that breathlessness, which is sudden in onset, associated with chest indwelling and deep breathing. Mother also gave history that child consumed lots of fruits, which include apple, banana, watermelon, etc. And after consuming this, breathlessness was started. No history of fever, no history of cough and cold, no history of headache, seizure, altered sensorium, no history of abdominal pain, diarrhea, and vomiting. Past history, patient was admitted in the past 2 times when baby was 1 year and 1.5 year respectively due to breathlessness. When baby was 1.5 year old admitted at our hospital, past record was noted. On examination, respiratory rate was increased and on auscultation, chest was clear. Per abdomen showed hepatomegaly. At that time, chest X-ray was done, which came normal, and ABG showed metabolic acidosis. So we are suspecting that metabolic cause. So we sent TMS and urine for GCMS, which came normal. Antenatal history, first trimester, second trimester, third trimester, not significant. Natal history, child was born by normal vaginal delivery full term with birth weight of 2.5 kg, cried immediately after birth. History of SNCU admission was present when baby was day 3 of life, admitted for 7 days for neonatal convulsion, but at that time no etiology was found and no anti-epileptic drug was given. Postnatal history, child was exclusive breastfeed, and developmental history, no developmental delay was present. Nutritional history, prelactial feeding was not given. Child was exclusive breastfeed till 6 months, then complementary feeding was started. Immunization history, BCG scar was present. Child is fully immunized up to date as per National Immunization Schedule. Family history, no significant family history was present. Parental consanguinity was present. Socio-economic and environmental history, the child lives in a Pakka house having separate kitchen, toilet, drinking water from tap. The child belongs to lower socio-economic class according to modified Kusumi scale. On general physical examination, child was drowsy, lying on mother's lap. Pulse was 118 beats per minute, regular, volume and breathing was normal. All peripheral pulses felt equally and bilaterally, no radioradial and radiofemoral delay. Respiratory rate was 64 per minute, abdominothoracic with increased work of breathing, but no subcostal and intercostal suction was present. Temperature was normal, BP was 70/52, measured in infant cup in right brachial artery. CFT was more than 3 seconds. No pallor, edema, icterus, clubbing, cyanosis, lymphadenopathy. Neck veins not engorged and neck glands not palpable. On head to toe examination, head, eyes, ears, nose, oral cavity, face, all appears normal. Neck, no visible pulsation, chest, no precordial bulge, and genitalia was normal. Anthropometry, weight for age 13 kg, length for age 89 centimeter, mid upper arm circumference 60 centimeter, upper segment is to lower segment 1.4:1, head circumference 47 centimeter, which came normal. On examination, systemic examination, CNS, no neck rigidity was found, no neurological abnormality, no focal neurologic deficit, spine was normal. CVS S1, S2 audible, no murmur. Respiratory system, bilateral normal vesicular breath sound was audible, no adventitious sound was present. GIT, abdomen shock, upper border of the liver dullness is failed at second intercostal space and liver span is 7 centimeter. So after receiving the patient with proper history and examination, we did an ABG and CBG, which shows severe metabolic acidosis with hypoglycemia. We kept critical sample for TMS and urine for GCMS, serum lactate and ammonia. After that, we started dextrose bolus and then NS bolus. After securing the volume status, 1 loading dose of bicarbonate was given. We shifted the patient to PICU. The patient was gradually improved. We also gave injection ceftriaxone for 7 days considering the sepsis. So investigation which came, hemoglobin 11.6 gram%, WBC 16,000 per mmQ, neutrophil by lymphocyte 32/56, eosinophil by monocyte 8/4, normocytic normochromic, CRP 20.2 milligram per DL, blood ammonia 21.7 millimole per liter normal, lactate 7 millimole per liter which came increased, ketone body 2.86 millimole per liter increased, total bilirubin 0.63, SGPT 208 unit per liter, SGOT 281 unit per liter. ALP, sodium, potassium, urea, creatinine, chloride all came normal. At the time of admission, pH was 7.02, PCO2 7.1, HCO3 1.8, and anion gap was 28.5. This is the picture of ABG. And after this report, we are suspecting that our case is going to this line that plasma ammonia appears normal with acidosis with high lactate plus hypoglycemia. So the differential diagnosis is organic aciduria, fatty acid oxidation defect, glycogen storage disease type 1, hereditary fructose intolerance, pyruvate carboxylase deficiency, multiple carboxylase deficiency, respiratory chain or mitochondrial defect. So after the investigation, TMS and urine for GCMS report came with suggestive of fructose 1,6 bisphosphatase deficiency. At that time, MRI brain was done, which came normal. For confirmation, we sent DNA test, which came fructose 1,6 bisphosphatase deficiency, the gene responsible for this FBP1 gene. After giving this treatment, child recovered after 2 days. Acidosis was also corrected. We discharged the baby after 7 days. So follow-up, we discharged the baby with advice to reduce intake of fructose and sucrose containing food, mainly fruits and sweets, avoid prolonged fasting, febrile diseases, which could increase the risk of metabolic decompensation. The take-home message is if the patient admitted with respiratory distress with acidotic breathing with hypoglycemia, we should send TMS. Single TMS report could not identify the disease, and early diagnosis and restriction of fructose and sucrose containing food can improve the quality of the life of the child. Thank you.
Hello. Hello. Any question?
Yes, very interesting patient case. Any questions? Can I just ask all the presenters? There are some questions in the chat box for the past cases. So if you could answer this at some stage before the end of the meeting. Any questions for this case?
Yeah, very well presented, very well worked up case.
Okay, I think no questions because it was all covered in the presentation itself. Congratulations. Okay, next case, please.
Good afternoon, everyone. Today, my case is a twisted tale of journey of a virus into brain. My patient was Shahanur Mullah, 3 or 4 month old boy, presenting complaint with high grade fever for 5 days, cough for same duration, and difficulty in walking for last 3 days. Fever was high grade, intermittent, 2 to 3 spike of fever, 2 spike of fever each day for the last 5 days, responding to paracetamol, not associated with chill and rigor. History of cough and nasal discharge for same duration and progressively increased. Other family members also have same symptoms. On the 3rd day of fever, mother noticed that the child was unable to walk and fall down whenever he tried to walk. No history of vomiting, headache, rash, convulsion, no history of drug ingestion, trauma, antibiotic. History of cough and cold 4 weeks back. Birth history, term, birth weight 3.1 kg, non-consanguineous marriage, institutional delivery, cried immediate after birth. Nutritional history, developmental history, and immunization history within normal limit. Socioeconomic history, the lower middle class. On clinical examination, day of admission, the patient was drowsy with intermittent irritability. GCS 11/15, pulse rate 110 per minute, blood pressure 94/68 millimeter of mercury, respiratory rate 24 per minute, temperature 101.1 degree Fahrenheit. Cyanosis, pallor, rubbing, icterus, edema, all are absent. Biliary nutrition is normal, no lymphadenopathy. On CNS examination, the higher function, there is a patient drowsy with intermittent irritability. Speech confused, the meningeal sign is present. Cranial nerve within normal limits, all cranial nerve would not be tested. Motor system examination, the power of right and left, upper and lower limb, 3/5, and the tone right and left and upper and lower limb within normal limit. And CNS other examination, the reflexes, superficial, plantar, bilateral, extensor response, deep tendon reflex, bilateral, exaggerated. Sensory system, crude sensation, crude touch, pain sensation is preserved, but the temperature sensation could not be elicited as child was very irritable. Fine sensation, fine touch, sense position, vibration sensation could not be done, and the cortical sensation also could not be done. Gait, child was unable to walk, and cerebral sign, nystagmus, pendular jerk, tremor was absent. Other system like respiratory system, CVS and GI within normal limit. An investigation of the day 1 of admission, there is a complete blood count, the hemoglobin 12 gram per deciliter, there's a 11 and total count 11,100 cubic millimeter. Neutrophil 31%, lymphocyte 58%. There is a CRP, ESR is raised, CRP 44 milligram per liter, and the ESR 75 millimeter in first hour. And also MPDA is negative. Sodium, potassium, urea creatinine, chest X-ray, urine RME are not. Other investigations like dengue, NS1, IgM, COVID RT-PCR, and COVID antibody, scrub typhus, Widal, Japanese encephalitis, IgM, CSF, and blood culture all reported 20. On the day 2 of this presentation, there is a MRI show there is a altered signal intensity in dentate nucleus of cerebellum. The possible differential diagnosis including the infective viral encephalitis, ADEM, metabolic encephalopathy, MISC encephalopathy, and stop typhus encephalopathy. The initial management with IV fluid, paracetamol, empirical therapy, IV ceftriaxone, IV vancomycin, azithromycin, and acyclovir. Other investigation is CSF, the cell count 2, all are lymphocyte, the sugar protein are normal, ground stain, gene stain within normal. Investigations dengue, NS1 IgM, stop typhus IgM, Widal and JE IgM all are negative, but COVID antibody is positive. The injection azithromycin stop and send D-dimer, LDH and ferritin. At the day 5 of presentation, patient progressively deteriorated, developed decorticated rigidity, and the GCS score 9/15. Blood pressure 126/76 millimeter of mercury, systolic blood pressure above 99 percentile, according to the age 5. Pupil bilateral mid-dilated and reacting to light, and fundoscopy papilloedema absent. Meningeal sign absent, deep tendon reflex absent, and plantar bilateral absence. This is the picture showing the patient, the decorticated rigidity. Other investigation including D-dimer, serum ferritin, and LDH all are increased. And injection mannitol started. In spite of all these treatment, patient clinical condition progressively deteriorated. Taking into the account the history, clinical features, CSF, MRI finding, and diagnosis as a MISC encephalopathy was considered. Injection methylprednisolone was started in a dose of 30 mg per kg per day, along with injection enoxaparin and tablet aspirin also started. Patient IVIG is not possible to give because of non-availability, and repeat due to patient progressively deteriorated, would be done the repeat MRI along with MR angiography and MR venography, and 2D echocardiography also done. The repeat MRI show there is a altered signal intensity in bilateral dentate nucleus along with chordate nucleus and putamen. There is a MR venography show there is a small filling defect in the straight sinus query thrombus. And 2D echocardiography show there is a coronary artery dilated with microaneurysm. And done ECG and repeat D-dimer. To rule out the other possible cause, we send for blood for ANA, CSF lactate, and blood for anti-MOG antibody. Injection acyclovir stop and continue injection enoxaparin. At the day 7 of presentation, the patient is afebrile. Clinically, patient showed gradual improvement and respond to verbal comment. GCS 13/15, vitals are stable. Pupil bilateral reacting to light. Deep tendon reflex decrease and plantar withdrawal response. My final diagnosis is this is a case of MISC encephalopathy, involvement of basal ganglia and dentate nucleus along with coronary artery. Started oral dose prednisolone 2 mg per kg per day after 5 days of IV methylprednisolone. Continue oral aspirin 5 mg per kg per day. Blood ANA negative, CSF lactate are negative, and blood for anti-MOG antibody also negative. There is a condition of discharge. Alertness improved GCS 13/15 and partial response to the verbal comment. Gradual improvement of muscle power 4/5, and the patient is to take oral feed. Oral prednisolone and aspirin continue, planning for discharge and follow-up. This is a case report in January 2022. There is a unusual involvement of basal ganglia and dentate nucleus in children with acute encephalopathy with COVID-19. Learning point: the multisystem inflammatory syndrome in children associated with coronavirus disease 2019 or pediatric inflammatory multisystem syndrome (PIMS) was initially reported in United Kingdom and United States in April 2020, following a surge of COVID-19 infection in population. It has the presentation of hyperinflammatory syndrome with involvement of multiple organs requiring timely treatment and inflammatory drug such as steroid and the intravenous immunoglobulin. The WHO criteria for diagnosis of MISC, all the 6 criteria must be fulfilled. Number 1 is age with 0 to 19 years. Number 2, the fever more than equal to 3 days. And number 3, clinical sign of multisystem involvement, at least 2 of the following. It including the rash, bilateral mucopurulent conjunctivitis, mucocutaneous inflammation, signs as mouth, hand, and feet, and hypotension or shock, cardiac dysfunction, pericarditis, valvulitis, and coronary abnormality. And evidence of coagulopathy like PT, INR, and D-dimer is acute gastrointestinal symptom like diarrhea, vomiting, abdominal pain. Number 4, the elevated marker like ESR, CRP, and propelcitonin. Rule out the other diagnosis. No other obvious microbial cause of inflammation, including the bacterial sepsis and the Staphylococcus, Streptococcus toxoid syndrome, and the tropical infectious diseases like malaria, dengue, staph typhus, leptospira, and enteric fever. Number 6, the recent or current SARS-CoV-2 infection or exposure. It including the any of the following test positive. Number 1, the positive SARS-CoV-2 RT-PCR or positive serology or positive antigen test or positive contact with individual COVID-19. The conclusion. This atypical presentation of MISC with acute encephalopathy and abnormal neuroimaging finding in pediatric age group may help in clinician to timely diagnosis and management. It will improve the outcome. Thank you.
So thank you, Imran, for this case. And then for discussion, any question or correction? Hello, madam.
So I think Dr. Mihir Sharkar is here. Dr. Mihir, any comments? It is your field of interest, I think, MISC. And any other comments from any of the others, judges? Are you getting a lot of MISC cases or is this an old case?
No, madam, still this is going on. Actually, every cases when we do test for IBA, immunoglobulin for COVID, all cases are positive.
Yes.
Even starting from
Yes, but it is difficult to know how old that infection or that contact is, isn't it?
the
If
history
it is
contact-
just antibody.
No, no, it was good.
Sorry, sir. Sorry, think.
If history of contact sure.
History of contact, family member or all are symptomatic, right?
No, which family members are symptomatic, but there was no definite not tested, just don't done. But what is surprising is that in spite of without vaccination, all cases are whatever, whenever we do test, it is positive. Going to be
I
positive.
think they have all been exposed.
Antibody
Yes.
is positive.
Did you mention a CSF finding in this child?
Yes, ma'am. The CSF is normal. Sugar,
Okay.
protein, and simple.
Okay.
I have a query. Can I ask?
Yes, yes, please.
Antibody you have tested, which antibody it is, IgM or IgG?
Sir, here is only available IgG antibody.
Recent infection only we can, if you do IgM, then you can say that is a recent infection. IgG may be old infection.
Only.
And another thing, you mentioned in your clinical this thing condition, there is a decorticate posturing, na?
Okay, yes.
So decorticate posturing means there is a sufficient damage, and so prognosis is also very guarded, I think, in this child. So that kind of MISC is in COVID. Is it that much common, or is it very rarest form of MISC presenting like severe brain damage?
So actually, this is a actually rare presentation. There is a 2 case report in early January 2022. There is a actually presented with same type of presentation, but outcome is very good. Within 3 months, there is a good outcome is happened.
Tuberculosis exclude করা হয়েছিল?
Yes, ma'am.
Tuberculosis exclude করা হয়েছিল? Decorticate posturing কিন্তু tuberculosis এ আরো বেশি কম।
Ma'am, CSF report are normal.
আচ্ছা, সেটা হতেই পারে। উদানি তো 23 রকম না তারও বেশি মেনিনজাইটিস বুঝিয়েছে, তার মধ্যে নরমাল সিএসএফ ও আছে, ওটা কিছু না, কিন্তু টিউবারকুলোসিসটা এক্সক্লুড করার দরকার ছিল, কেননা ডিকর্টিকেট পশ্চারিং যেখানে সেখানে এটা খুব ইম্পর্টেন্ট।
Okay, I think if there are no more questions, আর কেউ কিছু বলছো? So shall we conclude and ask the judges to take over and if they have any comments, and then to announce the first and second positions?
মধুমিতা তুমি কিছু কমেন্ট করবে?
Yeah, my only comment is all the cases were very well presented, very well presented, very well worked up. They seem to have worked very hard on preparation for this clinical meet. Well done. And ma'am, Madhusmita ma'am, I would request you to announce the prizes. It was very difficult. Ma'am will also agree that it was very difficult to choose first and one and two. But all of them were equally good, but still, as instructor, we were given instructions to choose two. So, ma'am, please you announce. Thank
So
you.
we decided that Shantanu Roy was the best first, and the second was Riya Guchai.
Yes, Riya Guchait's case on a thin on the ground case of honeybee. And Shantanu's was a sweetie storm in a pain child, that is Rogers syndrome. Rogers syndrome is not that uncommon, but Rogers with diabetes is probably very, very rare.
Very rare. So Shantanu Roy is first, and second is Riya Guchai.
Wonderful. So, Dr. Ghosh, we will arrange to send the certificates to you. Shabai Pabe, all the presenters will get certificates and special certificates for the first and second position holders.
Shabai prize power moton, proত্যেকেই prize power moton.
We will send it by post.
আমার একটু বলার আছে তারাপদতার ব্যাপারে।
Please. হ্যাঁ, please, শুভাশিস।
যেহেতু আমি মিদনাপুর মেডিকেল কাজে কাজ করেছি অনেকদিন, তা আমি জানি how difficult it is to do all these thing investigation. So আমি মানে খুব sincere thanks to Tarapodota and his team. Tara did all the investigation and ultimately they reached a final diagnosis. This is very excellent.
In all of these cases.
The diagnosis is very difficult. It's not very simple. So they ultimately diagnose all the case. This is actually they should get.
And I think every single complex and rare investigation was also managed and treated. So, খুবই ভালো লেগেছে. Fantastic work done.
Thank you all. Thank you.
সুস্মিতা তুমি প্লাস প্রত্যেকটা সার্টিফিকেটে দিয়ে দিও।
ঠিক আছে। অভিজিৎ দা কিছু বলুন।
না, বলার তো কিছু নেই, সমস্ত কেসগুলোই তো খুবই ইন্টারেস্টিং, এবং যেটা মধুমিতা বললো যে খুব ভালো ওয়ার্কআপ করা হয়েছে, এবং ডক্টর ভট্টাচার্য যেটা বললেন যে রিলেটিভলি রিসোর্স পিওর জায়গাতে এইভাবে স্টেপ বাই স্টেপ দিয়ে যে ফাইনালি ওরা ডায়াগনোসিস করেছে এবং ফলো আপ করেছে, হ্যাটস অফ টু দেম।
না, এটা আমাদের পিজিটিদের একটা দেখেছি, ওরা শেষ পর্যন্ত পৌঁছানোর চেষ্টা করে, যদিও উই আর হ্যান্ডিক্যাপ টু সাম এক্সটেন্ট ইন মিদনাপুর, স্পেশালি ইনভেস্টিগেশনস। অনেক সময় যেটা হয় পার্টিকে কনভিন্স করানো খুব মুশকিল হয়, তো সেটা একটা প্রবলেম আছে। কিন্তু অ্যাকচুয়ালি উইল টু গেট সাম অ্যাসিস্ট্যান্স ফ্রম দা ওই যেটা আছে আর কি, ওই গভর্নমেন্টের কিছু ফান্ড আছে, ওই ফান্ডটাকে একটা ইউটিলাইজ করি আরবিএসকে, তার সঙ্গে কিছু কন্ট্রিবিউট করে বা ইয়ে করে বাইরে থেকে করে আনতে পাই আর কি। তো আদারওয়াইজ মানে ল্যাবরেটরি ফ্যাসিলিটিস আর সেটাই হচ্ছে কথা।
ঠিক আছে, থ্যাংক ইউ। আর কারোর কিছু কথা যদি বলার থাকে,
যেটা ম্যাডাম যদি সার্টিফিকেট গুলো কি এমনি অনলাইনে পায়, এরা ডাউনলোড করবে না
আমরা পাঠিয়ে দিই, কুরিয়ার করে পাঠিয়ে দিই আপনার কাছে, কারণ সুন্দর ভালো প্রিন্ট করা সার্টিফিকেটস আছে।
থ্যাংক ইউ।
হ্যাঁ, আমরা পাঠিয়ে দেবো। ঠিক আছে, থ্যাংক ইউ সো মাচ। ক্লোজ করি তাহলে মিটিংটা। And thank you judges, thank you very much for very useful comments, constructive comments. Somnath, thank you. Close করছি।
ডক্টর ঘোষ, ডক্টর তারাপদ ঘোষ, যদি আপনার অ্যাড্রেসটা একটু এখানে পাঠাবো, সার্টিফিকেট গুলো যদি একটু আমাকে হোয়াটসঅ্যাপ করে দেন খুব হেল্প হয় আর কি, তাহলে সেখানে আমি কোরিয়ার করে দেবো।
হোয়াটসঅ্যাপে পাঠিয়ে দেবো।
হ্যাঁ, আমাকে একটু পাঠিয়ে দিন প্লিজ।